Welcome to our July 10th meeting featuring our favorite psychologist, Dr. Kim Gorgens, who will talk to us about the all-important relationship between the patient, the caregiver, and the medical provider. Like Bill said, my name is Shelley Mathis. I work with Bill on programming. And one of the things that helps us put these good programs together is your donations. Not to sound like public television, but if you go to our website, pfwarriors.com, I think we have a donate button on every page, and we really appreciate all the support you've given us already in the past. So, Dr. Kim Gorgens, PhD, ABPP professor in the Graduate School of Professional Psychology at the University of Denver. She's here today. She wants you to talk to her. She wants you to interact. But first, we're going to ask you to interact with us by answering, I think it's 4 survey questions. What do you think, Dr. Gorgens?
Shelley, these are beautiful questions, and thank you to you and Bill for having me back. You guys will see every day. I'm doing my part, right? I've got my warrior mug, thanks to Shelley and Bill. Really, they're 2 of my favorite people, and I think this is the most extraordinary group of people and caregivers. I see a lot of familiar faces. I'm really excited that you guys would be willing to have me back. Shelley and I talked a little bit about how to structure this, and we thought it might be helpful to open with this Q&A format and open that also to your experience. And Shelley, if it's helpful, because I am a helpless academic, this is like the hat that I wear, and you guys are stuck with me and foolish enough to invite me back to talk about research. But what I thought I could do is just share a summary of the research, which is an echo of the experience of all of the caregivers on the call.
Absolutely.
It can be really jarring to see your experience in the research, and sometimes hearing these numbers can make it really vivid. What you may not know is that you're in good company. Almost 44 million people across the US are acting as a caregiver in some role. The cost, the invisible costs, so these are lost work, this is lost productivity. The invisible costs for caregiving for lung disease alone, it's more than $3.5 billion a year. So if you think about the toll, the economic toll, that's really huge. The psychological toll, though, is extraordinary. And this is the experience of everyone here, and we're going to talk a lot about how to manage that. What is true in research, between 80 and 98% of lung disease caregivers report that they feel sad and burned out. If you look at, drill a little deeper into those numbers, 65% of folks have sleep disturbance. We can talk more about that because that's going to be a really key piece. 75% of folks have had to give up all of their pleasurable investments in life. And 96% of folks report that they have clinically significant sadness. Some colleagues of mine, this is an older study from 2003, but good colleagues of mine at Ohio State University did one of the first big control group study about caregiving. So this was family members of people receiving care at Ohio State University Medical Center. And you might not be surprised, but these results are stunning. They had to replace 70% of the caregiver group because they passed away. The mortality rate in the caregiver group relative to the community control group, so these were folks matched for age and other variables, it was 63% higher in the caregiver group. So there's something so preventable about these really terrible outcomes. We're going to talk about all the ways to prevent even those mid-level distress, so sleep disturbance, loss of pleasurable activities, sadness. We're going to talk all about that. There's also an increase in caregiver distress in COVID. So just for the last year and a half, this is no surprise to everybody here. And we can talk more about the unique challenges that the last year and a half and potentially the next year or so will look like. There's an increased risk for violence on both ends. So for caregivers to be targeted by the people that they're caring for. And there's a risk for people who are being cared for to be on the receiving end of some of that increasing irritability and agitation that their caregivers may experience. And we're going to talk today about the changing landscape in the healthcare system and how to feel like you can invest as a partner in the care process. And we're also going to talk about all the ways to hack your experience so that you don't end up in those statistics, because likely you already are. And let's talk about how to fix that. And what Shelly and Bill know about my commitment wearing my psychologist hat is that I think a 50-minute hour is a great fit and a great resource for a lot of people. I also think there's a way that psychology doesn't translate itself as well to real-time immediate solutions. And my attention span and the way my life works, this is the way all of your lives work too. Like, you need strategies that work in real time and you need strategies that fix the problems. So we're going to talk about those. So, and I've got strategies and notes and everything that I want to share with you guys along the way. Shelly has provided some really helpful anchors for all of the content that we'll cover. So I've got a 3R model, and we'll talk about all the hacks to reduce cortisol and et cetera, et cetera. So we'll talk about all of that. But Shelly, your first question was how do providers manage a mismatch, which is either between the provider and a caregiver, the provider and the patient, where they might align with the caregiver. And the changing landscape in medicine is around outcomes. And for lung disease, those outcomes can be really challenging to measure. And one of the benchmarks is satisfaction. So that works in your favor because all of those healthcare systems require physicians to measure, and here we're using the word outcomes in quotes. One of the outcomes is how satisfied you are with the care you receive. So their commitment, even if not altruistic, their commitment to your satisfaction and your caregiver satisfaction is real, because at the end of the day, it means their continued participation in that medical network. So there's an incentive there that you can use to your advantage. So we'll talk about ways to hack that system, but the providers need your help to figure it out. So they've got limited time to do that. And this is where either the patient and their caregiver, one or the other, takes the reins to lead the process, to dictate how much information you want shared, to dictate how much of that you want shared in paper to take home and review and field questions at a later date. They want to know how much time you want to spend with a nurse relative to, let's say, your PA or your physician. Everything about your care is dictated by your team, which is you and your caregivers. Shelly, I don't know that that fully answered the question about the mismatch with sometimes folks come in, they've spent a lot of time, and this is a benefit. So I don't want to give you the impression that that physicians scoff at patients who've spent a lot of time doing due diligence, researching their disease. That's a good thing. And of course, physicians working in emergency settings are going to roll their eyes when someone comes in because they've been on WebMD and they've diagnosed themselves with some like super low frequency base rate disease. But in the settings where you find yourself, those physicians rely on you being well educated. So your outcomes are actually dictated by how clearly you understand the process, whether you're at the phase of transplantation or at chronic disease management stage. So this is the mismatch might be your physician asking you to do more homework, and you might not want to take homework home, and instead you want to spend time with the nurse, and that's fine, and you can ask for that. The mismatch might be that the physician says, I want you to spend less time researching online, and here are some suggested journal articles or book chapters that you could read, right? The mismatch might be you're reading the wrong information, and they could have suggestions about that.
Yes, well, thank you very much, because And I think we just found out some very good information from the patients that are here today. They were not afraid to change providers. Right. And now they're, for the most part, they're very pleased with their provider. So I'm proud of our group of warriors.
Yep.
Okay. Well, now remember, you guys, you all, as we say in the South, you can, leave chat questions, or you can raise your hand if anything comes to mind. But we'll go to a patient-related question now. That is, what if the chemistry isn't good between the provider and the patient and the caregiver, and you really want to change, but what do you say? How do you do that once you've invested a lot of time with one provider and it's just not going well? What do you say? Maybe they have a crummy back office that drops the ball. I mean, what?
Yeah. Shelley, that latter piece is a classic example that I see all the time when we're doing physician education, is that, and especially now, I don't know what it is about healthcare administration that has just lowered the bar across the board so that patients experience making appointments, getting calls back, getting in touch with an actual human being at an office is at an all-time low. So that really is a challenge, and it may or may not be a reason to change offices. So understanding that that's a problem across all healthcare systems may change the tenor of how you think about the relationship you have with the physician. So that said, that's of the two relationships that we're talking about today, the relationship with the person who is your wingman, wingwoman, that might be your husband or wife or a partner or a good friend. It may be a sibling, a family member. So your person, we're talking about that relationship. And we're also talking about the relationship you have with your provider, your primary, whoever that might be. Let's say it's your pulmonologist. So those two relationships are essential for your good outcomes. So that's managing day-to-day disease, but it's also long-term outcomes. So it's long-term health outcomes and quality of life outcomes. So the relationships matter and the stakes are high. Here's what we do see happen in clinical practice. Sometimes caregivers will emerge as the drivers of care. And that's totally fine, provided the patient is on board with that, right? Some people, and I am looking around and you can't tell if I'm looking at you or not, but some people are nodding like, oh, that's totally me, or that's totally my husband, or that's my wife, or my sister is that person who brings the logs of every contact we've had. They've got my lab results. They ask for copies of everything. They hold the system accountable. So sometimes that role, that driving seat role, is reserved for the caregiver. And sometimes that might be the patient, and the caregiver's role there is social support and moral support. So it could be in any of those roles. What's important, though, is that both parties feel heard and seen by that physician. So let's say, again, that that's your pulmonologist. One of the pragmatic considerations is just around paperwork, right? Ensure that if you are going to be a primary caregiver, that you're listed in all of the releases of information so that that office can talk to you if you called on the phone, for example. Certainly, they're going to talk to you in the patient's presence in the room, but you want them also to feel like they could return a phone call if you had a question. So the relationship may start with just the signatures, the legal signatures, but then it gets built on that rapport and the degree to which you feel like you're heard, you're seen, your opinions, your responses to the questions that the physician might ask are validated is really key. So if, let's say, you feel unheard, you have a hard time reaching someone, you leave appointments with your questions unanswered, and your loved one, their care is in some way, whatever you've defined that as, in some way is subpar, it really is time to shop around. And it looks like half of you, 48% of you, have made that decision. And it likely was a combination of those two things, right? It was like, I think they could get better care. I think they could get more attentive, personalized care. And I don't feel like the physician really knows us, knows me, respects me, hears me, whatever the case is. So you bet there is a universe of care providers out there, and you want to be really thoughtful about finding the person who delivers the best quality care, who also makes you feel the most comfortable in terms of rapport. And interview folks, right? You should not be afraid to ask for a consultative appointment and meet someone and ask, what are your policies on caregivers, and how do you involve family members in the delivery of your care and long-term care management?
Is it okay to, if it's a lot of times it really is the back office dropping the ball, like they are so supposed to process something so you can get your oxygen or you can get this, and they're sitting on it or something. And is it really okay just to go back, instead of to the back office, go to your main provider and say, I'm really struggling with so-and-so, or what do you say?
You bet.
Okay.
And almost always that physician will be horrified to hear that, right? They're relying on them to, like, I need you to manage all that stuff and I need not to see it, right? I just need to know, like, who's on my schedule, who am I going to see, what conversations will I have today? And I need you to manage reimbursement and claims and scheduling. So they're going to be horrified, but they do need to know that. Oftentimes, there may also be an office manager. Sometimes, frankly, they're part of the problem.
Yeah, we've seen that.
Yeah. And Shelley, you're right. It is things like getting a claim processed. It's getting reimbursement going. It's submitting prescriptions on time. It's refilling things so that you don't have a delay at the pharmacy. These are the kinds of seamless, day-to-day, needful things that those admin staff members really need to be following up on, that we're finding more and more are falling by the wayside. And that, again, hopefully will change. Right now, there is a real lack of a qualified workforce at that administrative level in healthcare settings. So with luck, that changes over time. But right now, it's a real crisis.
Oh, yeah. That's, for any young person going to college, that's where the jobs are.
Healthcare. Like that. Yeah, totally.
Okay.
Shelley?
Yes.
Increasingly, we're finding that the staff that work in a physician's office don't work for the physician. They are, if you will, rent a staff type situation. And there is a real disconnect in the communication between the physician and the staff.
James, this is such an important point. A lot of times, depending on that healthcare system, that administrative staff is employed by the healthcare system in the same way that the physician is appointed to the healthcare system. So they weren't chosen by or hired by the medical staff there. They aren't supervised or evaluated by those medical staff. So it can be a really tough dynamic to navigate if your healthcare provider has no leverage whatsoever. Yes. It doesn't mean that they can't run a complaint up the food chain on your behalf. You can think about reaching a critical mass when your healthcare provider hears from enough folks that there's lengthy delays in paperwork and refills and getting oxygen tanks approved and delivered, and returning phone calls to schedule follow-up appointments. That's going to prompt longer-term change.
We also got a good chat comment about having difficulty getting back to the provider. You have to go through that office that's doing such a bad job, and the staff is sort of a brick wall. So do you send a letter, or what do you?
Or if you can even get a person, right? A lot of folks have the experience of leaving voicemail and you're waiting to hear back. Or I see the one person who, you log into my chart and you flag yourself as wanting an appointment, and then you're waiting to hear back. James, I think your partner had a hand up.
Yes, I just wanted to say that I have turned into an admin since all this happened, and even before, and I am consumed by paperwork, phone calls, keeping track on spreadsheets of all the different people. And also, of people that if you find some office manager who happens to be good and you're lucky enough to get their personal number, and then all of a sudden they're gone and replaced by someone else, we got to start all over again. And it has been a consuming task to keep up with the amount of, and you have so many doctors that you have to keep up with. And then you have to change doctors because you're not getting the correct service. And then you have portals to go to that all need new information, and you have to spend time on portals that don't work. It is all consuming.
It's a job.
I don't know what the answer is, but the problem is that is multi, there's many things going on here. And but I must say that it is incompetence in many areas.
Mm-hmm. Tell us your first name.
Marianne.
Marianne. Marianne, you are the exact person that I'm talking about, where you have the fierce, dogged, tireless advocate who is right by your side, who's tracking everything.
She is my advocate. I'm the patient.
Yes. If everybody had a Marianne and we could keep the Mariannes of the world afloat, we'd be batting 1,000.
No, that's not true. I disagree. It would be insufferable to have a Marianne. Insufferable. You would have to have a particular patient who would be able to come up with me. But on the other hand, I do get things done, and we do have changes made ultimately. Most of the time, not always.
Yeah.
Thank you.
Marianne, it's also a great strategy in tracking some of that. And we could use the term incompetence as kind of a writ large. It's slow turnaround, it's lagging prescriptions, it's whatever, that laundry list of failings that you experience from the office staff. If you can keep a log of that, that's a great way to arm your physician with information to run up the food chain, right? Because they're tracking at that most granular detail. Those systems are tracking outcomes like that. So it's number of hours for return phone call. It's the number of days for first appointment. It's number of months for second appointment. So you bet you could track all of that. And if you could package that as feedback.
Well, I mean, there's certain things that you can deal with the physician, and certain things that you cannot, because you have to know your limits, and you cannot, say, how come you didn't schedule an appointment after our telemedical that we're supposed to have 3 months later? No one called us or anything, and then when I go to realize that it's been like over 4 months, and I'm go to get an appointment, they say, well, you have to wait 3 months. And I said, well, is that for an established patient? Well, so, I mean, there's only so much you can do in some cases, because you don't want to, burn bridges. Okay. So there's certain things you have to let go and put up with. And if they're not that important, you have to realize that, hey, we're dealing with another hospital that helps them anyway, because we're dealing with multi-hospitals, multi-doctors, and if there isn't one, there'll be someone else to.
You bet.
Yeah, great comment about not burning bridges, isn't it? Actually.
Yeah, I have to stifle myself many times because I get so frustrated when I'm getting the runaround, and I get the runaround all the time.
Well, we did burn bridges once, and we, as a result of being with a doctor for 15 years, on the spot, we made a decision to get out. And that was a good decision, and it was on the spot, and there was no problem at all in getting out. We just called up and said, we switched, and we got someone else now.
Well, I'll tell you, I know Marianne, and she is a powerful woman, and I would not want to come up against her. But speaking of caregivers, Dr. Gorgens, you had a very interesting article in Rheumatology Network, May 12th, 2021. When I think of what does it mean to take care of yourself, as a caregiver. I didn't know what that meant, but something you wrote was very interesting to me. If you don't already know something, this is from your advice to a provider. If you don't already know something about a patient support system, ask their network and their caregivers in their lives. Make a point to retain your patient-centered model of care while also recognizing the value and importance of the caregivers. Perhaps consider inviting them to an upcoming meeting. And you go on to say, importantly, as you recognize caregiver distress, see below, more than anything, remember you have everything in common with these caregivers and they are your important allies. The chart that you gave of caregiver burnout shocked me. You have 8 points: complaints of feeling tired and run down, withdrawal or avoidance, deteriorating health, headaches, reported changes in sleep or appetite, apparent lack of interest, hope, or motivation, apparent trouble concentrating or increased distraction, obvious lapses and changes in healthcare, reports of increasing stress, anxiety, and depression, and observed impatience or irritability. I have 7 of those 8. And I thought it was because of the pandemic.
She has all 8.
But tell me, what exactly do you do to take care of yourself? I mean, I'll have to fly to Hawaii. But what do you do?
Shelley, I love that there's so many people chuckled to themselves and were like, same, totally same. And the sameness is 98% of caregivers are in that boat. And it's extraordinarily hard. And the important thing, and maybe this helps normalize the experience, is that the baseline is hard. So it's not like you're getting back to a completely stress-free lifestyle. This is a stressful lifestyle. So this is all about how to manage that chronic stress and how to manage the stress, importantly, so that it doesn't take a toll on your mental and physical health. So the idea of arming yourself with strategies and tools is so important. And anyone who talks about, living a stress-free life or reducing the stress in your life altogether, right, is living some other life, and they're not managing a whole universe of data related to your loved one's medical care. So that being said, as I work with patients, especially on the chronic disease side, I think of this category of I love a simple way of thinking about things. So I think of this category of 3 R's largely, and this for caregivers. The first, and these are all caps, the first is around recharge. And this is a chance, and the second is respite. So they're kind of closely related. But a recharge might be, and this is in all seriousness, a recharge might be a very brief mindfulness exercise in the bathroom for 60 seconds. That may be all the luxury you have, is to close that door, sit on the toilet for 60 seconds and use a mindfulness technique, which we know in the research changes your physiology. So this recharge, it might be going for a walk, leaving the house, it might be leaving the room, it might be turning your back, it's whatever it is, momentarily recharge your batteries. If you're someone who has, and I'm using this term partly in a flip way, hobby, then it's the time you spend engaging in that hobby. For a lot of you, you hear the word hobby and you think that it's oh my God, I wish I had the kind of lifestyle where I had time for a hobby. So I just also want to say that. So you may not have the room to be tying flies at your desk because you are someday going to go fly fishing, or that you're quilting, or whatever the case may be. So if you have something that recharges your battery, it's the time you spend doing that. People can also recharge our battery. It may be just the one person that you enjoy spending time with, or the one person who makes you laugh. For some of us, it's not being around any people is the recharge. So understanding yourself enough to know, like, where do I get recharged? So this is tremendously draining, and the recharge is key. So you might even think about it if you, as we're talking, can't think of a circumstance where you feel recharged. You might approach it as a researcher and start logging the things that aren't working. So recharge is the first. Respite is the second. There is this, I cannot overstate, the importance of tagging out is key. And caregivers feel shame around needing to take respite. And I want to reframe that to be like, if you're not using respite, then you're killing yourself. This is not sustainable. So you might get respite from another family member, from a trusted friend or caregiver. You might also lean on your medical providers network of respite care providers who could come into the house. And this might be to have lunch. For some care providers, it's, listen, I want to take a bath for an hour. I want to soak in the bathtub until my skin prunes up and not have to think about anyone else. That's also respite. So tagging out long enough for you to feel on the recharge side, but tagging out might be getting away even for a weekend. And again, there's not only no shame in it, the shame is in not using respite. So that is like a really important take-home point, is to find out, have a short list of who you can lean on for respite and use that, right? You've got all kinds of support network members who say, let me know how I can help. That's a great way to tell them how they can help. Hey, would you come and sit and just make sure that while my husband naps, he doesn't knock his oxygen mask off? Okay, sure, I could do that. Or like, come over and play cards for the afternoon or for the weekend. And then the third R, wearing my psychologist hat, is to reach out. If you notice, and this is where you have to be a really astute observer of yourself, if you notice a change in any of your areas of functioning. So let's say you notice that you're not sleeping as well and you're waking up feeling more tired, or you notice that your appetite has changed. Maybe all you want to do is eat all day, or just the opposite. Like, I can't get myself to eat anything in the course of a day. Maybe you notice that the change is that you're more irritable. You feel less patient with your patient. Maybe the change is you can't bring yourself to take a shower or brush your hair or brush your teeth every day. So if you notice a change, the reach out is to get the help you need. So that might be asking that same trusted physician, hey, can you recommend a local mental health provider? Now it doesn't even have to be local, frankly, with telemental health services, but can you recommend someone who has experience working with chronic lung disease? And they should have a short list of folks that they've made referrals to in the past. So then you're not starting from scratch in the universe of Google of like, how do I find a psychologist? So start with your trusted professional. You could also, this on the reach out side, you don't have to wait for something to go totally off the rails to get the support to keep you afloat all the while. So this is leaning on the Pulmonary Fibrosis Warrior Network. This is Better Breathers Network, or whoever it might be, staying connected with your people. So this is with a network of people who share the same frustrations and the same challenges. This is a way to embed yourself in a community of your people. So it's really isolating, especially in COVID, right? More so in COVID than ever before. Being a caregiver is so isolating. So now virtually, to feel connected to your people is more important and easier now than ever. So it's recharge, respite, and reach out. So those are the three biggies. And we can talk about on the recharge side, as we move along through the questions, some really easy, low-hanging fruit kinds of interventions for mindfulness, ways to hack your sleep so that you sleep better, ways to think about stress and chronic stress and how do you metabolize cortisol better, and all of the ways that we can make the caregiving process take less a toll on your physical health. So it's there's a lot of really great ways to stay connected and to feel like you're armed with some really powerful tools.
I'm wondering if we can get Roseanne Dwinell she's been a caregiver. Her husband last year or so went through a transplant. Roseanne, how did you, as a caregiver through that arduous process, take care of yourself? You'll have to unmute yourself.
Okay, can you hear me?
Yeah.
Okay. Yeah, so Steve, it's been 2 years now since his lung transplant. That was a tough process. Because, he was in the hospital for 4 months and had a hard time getting weaned off his oxygen and stuff. But everything Dr. Grogens said is spot on. You do have to take care of yourself, and because then you can't take care of the patient if you don't take care of yourself. But the problem is no matter how much you tell yourself that, at least for me, I can't speak for anybody else because I think every caregiver is different, because it depends on your personality and your relationship with your spouse or whoever you're caring for. But with me, it was hard for me to reach out and ask for help. But because you have to put on different hats. While he was in the hospital, it was stressful enough going there every single day and then coming home to an empty house because he wasn't there with me. And I would get panic attacks. I'll admit to that. I get panic attacks. I got panic attacks like at 4 a.m. in the morning. Even one time called an ambulance because I wasn't quite sure if I was having a heart attack. But it's that's where it was hard for me when he was in the hospital to reach out. But I found through support, besides family and friends, I also found a ton of support through the people in this group that helped me a lot. Because when Steve was at home, he couldn't be left by himself, but I also needed time for myself. So with a lot of Shelly was one of them, Shelly and Scott, and several of my other friends in the PF world. They were, able to come and give me relief time, and I was able to spend time with somebody outside of, spending time with Steve. So that helps a lot. Trying to find that support system, but I'm going to be honest, it still didn't. I still had restless sleep, all those things that you pointed on. Not getting any sleep, not panic attacks, stress, trying to figure out what I can do to take time away from myself, and not even necessarily time leaving, but you're talking about like hobbies and stuff. Well, I'm a gamer, so it helped me to get on and play a game for a while just to try to forget. And because you do, as a caregiver, you wear many hats. You were talking about administrative stuff. Well, besides administrative stuff, you may be a nurse. I had to be a nurse for a long time for him because he had wound care that needs to be taken care of. So, you're a nurse, you're an administrator, you're doing things that maybe he, she, whoever your caregiver is used to do, but at that time cannot do it now. So you're covering for them. I'm trying to think of other things. I tried to pre-plan what I was going to say, but I'm not doing a very good job. And so you just wear different hats. I think we're all different, and you just got to find your outlet. You got to find your support system, because I know some people don't have maybe family or friends to lean on. So a group like this is awesome because you can find people here that are willing to, help you out if it's just a matter of talking. Because sometimes just having someone sit there and listen to you helps a great deal through the whole thing.
Amen to that.
I had a comment on that too. I'm Flo, and this is Nancy. She's my wife. She's my caregiver. And what we were talking about before is the giving up the control and the trust for her to give it up to someone else and go and have a cup, a day off, or, a cup of tea, or go for a walk or something, is that how do you help the caregiver? I'm not quite sure when I haven't had my transplant yet, but how do you help both of them? Because I'm not quite sure that I trust anybody other than her caring for me. But I suppose it depends on what stage you're at in your recovery. Do you have any thoughts on that, Doctor, or anybody else?
Dr. Gorgon?
I was just going to make one comment about what she just said. That's very true, because it was hard for me the first time. I've had, family and friends saying, I'll come over, I'll sit with them, you go do something. That was a hard thing to give up, because I would worry. It was just like when he was in the hospital during his lung transplant. I worried when I wasn't there. Like I would call the doctors really early in the morning, or the hospital up really early in the morning, because I wasn't there and I wanted to know what was going on. So it's a hard thing. For me, it was super, super hard to do that, to give up control. But you have to. And once you do that first time, it'll get easier each time after.
This, before we go to your comments, Dr. Gorgon, Alice Malik, if you wouldn't mind making some comments. Alice, her husband just had a transplant. Alice happens to be an RN. And she and I were talking the other day, and she remarked about how she couldn't understand how, like, just the average person who doesn't have her medical talent can possibly be a caregiver of someone who's just had a transplant. She listed off some of the things she did, and I nearly had a heart attack. Alice, could you talk about what you're experiencing?
Oh my goodness. Yes, actually, today is the 2-month anniversary of my husband's transplant on May the 10th. And he was only on the list for 4 weeks. So we did not have a lot of time. We were very shocked to get that phone call. And I've realized that we should have talked about things before, many things, because all we did was switch one world to another. Dealing with, he has a terminal disease, and suddenly, oh my goodness, we're in this very intense post-transplant world. And I have been a nurse for over 50 years, but I can honestly say it is overwhelming. Just his medical care involved a whole lot more than I was prepared for, honestly. He's had complications that, the transplant team continually say, this is normal. Things always happen. But it's not normal for us. And I really do feel sometimes that I've really lost the real person that I've been with for over 50 years. I'm finding myself in times wishing we didn't do it, honestly. And I know Roseanne probably understands that point. I have to stop and find that faith that it will be okay eventually. But yes, it's a huge job. I can't even imagine a person with no medical experience dealing with doing blood sugars 5 times a day and a blood glucose going up and down, dealing with someone who has been depressed, seems like a different person. it's a lot. And I have bent Shelley's ear many times, and I so appreciate that. I'm lucky enough to have family support. I have 2 daughters. When he was in the hospital for 44 days, we did not leave him alone. We shared it. My 2 daughters did the nights, and I did all of the days. And that helped me tremendously, knowing that he wasn't alone. But at home, I know that I'm the ultimate responsible person, and it is overwhelming. It really is. But I know I'm still new in the recovery process. But everything that Kim says is so true. You need to take time for yourself. But I'm guilty of not doing that right now.
Mhm.
Everything Alice you said is so correct. Because when your loved one comes home after, especially complications, because Steve had complications, and they're not, and then the first time they're on those drugs, they're not themselves. But I'm going to tell you, there is light at the end of the tunnel. There is.
I'm hoping for that.
You'll get them back.
Jim, you have a comment here.
Well, I don't know where to begin, but I want to say that
We're 2 years and 3 months or 4 months post-transplant.
yeah, and the comment about losing the person, I feel that I've lost Jim in many ways, just exactly as Roseanne and the other lady have said. And that my feeling is that many times I feel that, the person that I had is still there, but in an armor that he's inside and is locked in and can't get out. And that's exactly how I feel. But to other people, he's sort of like the same, but he's not really the same because of the repercussions of the lung transplant. You can't touch his skin because it hurts. He can't walk because the peripheral neuropathy has increased so much that he can barely, he has his cat trike, which is a blessing, and he does 6.2 miles when he can. But the other problems that he's having with other issues, dermatology, we've gone through 7 skin cancers. That's minor right now, but the other issues are not minor because he has to live with them, and the pain is something that he lives with 24/7. Right now, the pain in his extremities has been, even when he's sitting down, so there's no relief from the pain. But so, he's still there and he's still my husband, but somehow or other I've lost who he was. And that is something that I am coming to accept, because it's a realization that we have to live this way the rest of our lives, and we have to be extremely careful the rest of our lives. But I'm taking measures to get out on my own. I go for lunches with friends. I play the guitar. I have an online course with Justin Guitar that I absolutely love, and I try to spend time on that. I do Zoom exercises in the morning. I have, my brother who's very close. He's in Boston, but we talk a lot. I have a friend that I talk to, and so we have the support from the church. Jim gave a very good speech at the church, that Sunday school class on his journey, which is in Dropbox. And if anybody knows how to get a big Dropbox to be able to save, let us know how to do it, because I'd love to save it, but it's too big to save. Anyway, that's another story.
Well, maybe he can put it in our Dropbox.
Well, I've got it in the Dropbox. I just can't figure out a way to get it out of there because it's so big.
Bill Vick will help you.
I'd like to save it for, just to have it, even though my children are interested now. At some point, maybe they will be, but just to save it. But getting back to what I do, I find things to do that are, helpful to me. In order to stay awake, though, I must admit I drink a lot of caffeine and have a lot of ice cream sundaes.
Well, you're tiny. You can take
that is a daily ritual that I cannot seem to stop, but it manages to get me through the day, even if the caffeine is late at night, later at night. But somehow I'm making it through, and also with some help with medication, which I know that I have to be on. Mm-hmm. But basically, I just feel like we had so many things to face that we moved from one place to another, Plano to here, and then here to Houston very quickly. We had to move within a week for the transplant. We got down there, and then we got called for the transplant within 7 days of unpacking our stuff. And then he had the transplant, and then 6 days later, we had major surgery because of a problem. And so we went back to the hospital for that and had the major surgery with the patient, and then an ER visit. We had shortly after that drug intervention. I mean, we've just had so many. We had another ER visit up here in, for another thing that dealt with the urinary. We had a potential ER with drug intervention again. I mean, it's been a roller coaster, and I must say that I'm so glad we're near my son because he's close by if necessary, and my children are involved somewhat, and my daughter very involved. My son is on the periphery, but he's always there physically for the major things. And
well, Marianne,
thank you, Shelley. I was going to ask if Dr. Grogens can just comment, because Marianne is more typical than atypical, I think. And what are your feelings on what she's going through, Doctor?
Hearing Alice and Roseanne, Marianne, you two, it gets me a little choked up. Here's what you're living, and this is the perspective of someone who works with patients and their families who have all manner of chronic illnesses and disability. There is something really unique about lung disease, pulmonary fibrosis, even more singularly. There is something uniquely challenging about being a caregiver. The disease course, Marianne, you used the word roller coaster, and it's a lot like that. And that's not typical of a caregiving responsibility for someone with a neurodegenerative disease or dementing disease, let's say, for example, late stage cancer. These are deteriorating conditions that have a whole unique set of challenges, obviously. But what those diseases don't have is this kind of up and down course where every day brings a new challenge and a surprise, and you really can't see what the future looks like. And I thought it was so poignant, Roseanne, for you to be able to say to Alice, like, I walked that, I'm here now, this is how I got here, this is how it will look different. And it's so special. And that's really the testament to the benefit of finding your people and the people who understand and who walked that road and can weigh in with even just the reassurance to say that this changes. The other really important piece, and this for the couples who are listening. So there's also, in addition to PF is one of the hardest diseases to be a caregiver for, it's also hardest to be a partner caregiver. So versus a family member, some of you may have a parent or a sibling or a kid who is involved. To be a spouse or a partner is uniquely challenging for all of the reasons that you guys have alluded to. It's remarkably hard to have all of those different roles. So it's nurse, it's admin staff, it's triage, it's psychologists, you're treating your spouse, partner as if, right now there's some stranger. And in the context of it's steroids, it's everything else, they actually are a stranger at sometimes, right? And their personalities are very different and they're scared and it may make them lash out and they're more irritable and your temper is short because your patience has worn so thin. So there is a really unique challenge to being a caregiver in a relationship. And we should have a whole separate one about how to navigate your way around the caregiving relationship for partners, because there is a whole conversation that we really haven't had about how to return from a caregiver role, doing wound care, to being a sexual person in a relationship. So, right, like there's a lot of real estate to cover there. And it's really challenging and really important for you to cover that ground. With Nancy and Flo, your question about how do I leave the house? How do I address the shame and the guilt that you have as a caregiver to tag someone else in who may be less responsible, who's going to know less about your partner's care? Here's the most crass answer of all times is you just have to. It's not sustainable to not do it. So you find the best avenue you can. If you have worries about the delivery of care while you're gone, you might tag in a healthcare provider and think about all the ways that you would do it. If you could design it, think about what would I need to like truly feel unplugged for the 2 hours for my girlfriend to take me to lunch, or for me to, take a walk around the park or just take a drive. If what you need is, I just want to be able to like see on my phone what they're doing at the time, then set up a webcam, right? And like, if you need to, like, I'm going to set myself a timer so that I only look at that webcam one time in the 2 hours, right? Like, okay, I'm going to check in at home, and that's okay too. It's whatever gets you out. And I'm saying out, it may not even be out of the house. It may be to just step out somewhere else and have your own time. For patients, it's also really nerve-wracking because they trust the one person. They've come to rely on you, and it is hard. Intellectually, they know that you've got to go. You need the respite, but their heart is saying, like, I'm kind of afraid to be left alone with someone that I don't know, or, with Patty down the street because she brought a casserole, right? I don't even know her. So there is a lot of tension, and there's no wrong way to do it. The wrong way to do it is to not do it.
I see Philip Taylor has his hand up.
Hi, am I unmuted? Yes, I believe I am.
We can hear you.
Okay, thank you. I'm new in this whole thing. I was diagnosed by a cardiologist in December and met my pulmonologist for the first time in March at UT Southwest. So again, I'm new and I'm trying to learn. I want to get out in front of some of these issues that we're talking about, particularly the caregiver. My wife has, that will be my wife, and she has plenty on her plate already. So any help I can give her, I'd like to. Dr. Gorgens, when you were talking about the 3 R's and you mentioned respite, you used the word techniques. You referenced some techniques. Could you point us to some resources, or at least direct me on how to search for that?
Yep. Totally love it. Philip, thank you for, I'm a little bit like I'm full of helium, and then I'm like, a balloon, and you have to like pull me back down by the string and say like, okay, but back to nuts and bolts here. So thank you for bringing me back down. If you think about the physiological toll that caregiving takes, it's increased exposure to cortisol. So I just like to think of the physiology of a thing because it's an elegant way of like collapsing all of the different ways of considering the damage that stress is doing. So the physiological damage of stress is chronic exposure to cortisol. And Alice will remember this from nursing school and from all the conversations she's had with patients over the year. We're not designed to be exposed to cortisol for longer term. Quick little sidebar, we're very well adapted to metabolizing short bursts of cortisol. We're actually designed to have a really elegant stress response, and then for that stress response to be resolved. And exposure to short-term stress is also beneficial for your brain. Note to Marianne, so is weirdly 5+ coffees a day. So it's like, there's something really neuroprotective about caffeine too. So don't feel bad about drinking that caffeine. Anyway, so chronic exposure to cortisol is associated with every poor health outcome. So it hardens your arteries, it increases the deposition of plaque in your arteries, it destroys the collagen in your skin, it erodes the lining of your stomach. It really is everything. So the ways that we can manage or increase our metabolism of cortisol. So one way to do that is to promote better sleep. And I teach graduate students all day long, and the most important message I give them is for their patients is to fix sleep. I say, if you're not making eye contact with sleep, then you're not doing any clinical work whatsoever. You may think you're doing great clinical work for depression or relationship distress or disease management, but you're not doing anything. So sleep, we metabolize cortisol when we sleep, and when we sleep poorly, too little, too much, or our sleep is fragmented, then we're not metabolizing cortisol. So fixing sleep is a big one. And I'll actually share in the chat, Shelley, you may be able to put your hands on this, but there's a new app that some colleagues here at the Denver VA have put out. It's called the CBT, Cognitive Behavioral Therapy for Insomnia Coach, CBTI Coach. And you can download it to your phone, and it's just like a pocket sleep hygiene intervention that is brilliant and developed by research on the most sleep deprived populations of veterans, returning service personnel with brain injuries and PTSD. So they look a lot like this group in terms of their exposure to trauma. So it's a terrific resource. Fixing sleep is a total key one. Another one, really interestingly, in terms of tools that's really well supported is the use of mindfulness. And mindfulness gets kind of a bad rap. I don't know that I would call it a bad rap. Maybe I would, but it gets a rap of being like, this is about long-term meditative sessions and crystal healing. And it gets a little bit like out there on the fringe and like, oh my God, I don't even know how to do that. And now I have to have someone teach me how to do it. And it's way simpler than that. Decades of research on the use of mindfulness to improve the metabolism of cortisol, to reduce a stressful state. And two of my favorite ones, and I just made some of these notes. So this, again, for a lot of patients, I may be caregivers, I may be talking about like excusing yourself to go into the bathroom. This might be like doing it in your bed in the morning before you get out of bed. If you can carve out even 60 seconds at a time for a brief mindfulness exercise, it has a demonstrable physiological benefit. So my two favorite really easy mindfulness exercises, one is the 5 senses, which is to sit, lay down, wherever you find yourself. Maybe it's like your private space is sitting in your car, closing the door and sitting in your car. That's totally fine. The 5 senses exercise is to slowly toggle through each one of your senses and in the most vivid detail possible, experience what that sense is. So like, what do you hear at the moment? What is it that you see? What's in your visual field? What do you smell? And it's a way of grounding yourself. And it has interesting EEG brainwave changes. Like it's totally interesting in the research how this shakes out. So 5 senses is kind of an easy one. It's a great grounding exercise. You can also use the five senses thing when you feel frustrated or you're losing your temper, or right, like you've been disconnected for the 10th time while you've been on hold, like you're about to lose your shit. You could use the five senses exercise, right? It's just a good way to get like back into your body. The other thing is a body scan, and there's great examples online. This is a way of moving head to toe to just check in with your body. What you'll find is you start to identify where you carry your stress. And, you know, for a lot of us, it's you wear your shoulders like earrings, or you might have a constant headache because you're grinding your teeth all day long. So it's like a great way to check in. And as you get better at checking in with your body, you get better at knowing when you need that recharge moment or to tag out more formally for respite. So those are some really great tools. The other category that I'll mention very briefly is cardiovascular demand. So the most important thing for brain health is cardiovascular demand. And people use the term exercise, which I hate, but it's just creating cardiovascular demand. So moving your body in whatever way feels good and makes sense for you. In the research, this is like in all the mouse models, the mice run on the wheel for 60 seconds at a time. So if you think about, is there a way to create cardiovascular demand for 60 seconds at a time as a caregiver? You bet. It's a couple of deep knee bends, it's arm raises, it's, you know, twisting in a chair, it's whatever it might be for 60 seconds at a time. That produces a hormone called BDNF, or brain-derived neurotrophic factor, which is directly related to suppression of cortisol production. So, and it's also like miracle grow for your brain. So it's like the best of all the like easy. I think it's so powerful that I tell my students that the clinical benefit their patients get from seeing them in our clinic may be conferred by the walk from their car to the clinic office. Right? It's like, it's that good for your brain. So Phil, are those helpful? Like basic CBT coach, fix sleep, mindfulness, right? Get some mindfulness tools on board, get your body moving in whatever way makes sense. Those are all going to improve the metabolism of cortisol, which is the end goal. One other, this is like an interesting little physiological note. So if you think about, oh, these are all ways to improve my physiology, which at the end of the day is mood, and it's the way you think, right? It's your body's capacity to respond to your circumstance. On the cognitive side, the way you think about the world and the way you respond to the world, when we get depressed, we develop a whole suite of negative connotations. So we think of the world in a more pessimistic way. So interestingly, what we know about the way the human body and our emotions work is that we are, it's called self-observers. So our emotions are actually just the labels we attach to our physiological experience. So, right, it's like our mind kind of hovers. It is like, I guess I feel scared, or I guess I feel excited. It's whatever the context demands, but the physiology is the same. And you can hack that to your benefit. So one of the easy, and you guys have seen this a million times, but the research is totally legit, is the facial feedback hypothesis, which is to take some time, carry a pencil in your mouth. What carrying a pencil in your mouth while you're doing something also does is like forces you to pay attention to how much you're clenching your jaw, right? Which is one of our kind of silent stressors that's causing all those headaches. So you're going to pay more attention when you've got a pencil in your mouth, and spend some time taking your lips off the pencil. And that's directly correlated to mood. So it's called the facial feedback hypothesis, which tricks your brain into thinking you're smiling, and your cognitions change. So, right, I'm not going to tell you that your life is going to be easier, but I am going to give you the tools to survive the challenging life that you have.
No, thank you. That's great. And it's a great starting point, and gives me something to work from and build. So thank you very much. Appreciate it.
Phil, thanks.
Also, Dr. Gorgens,
My pleasure.
in an earlier program you did for us, you mentioned the value of using melatonin if you're not getting proper sleep at night.
Yeah.
Is that still something that you would advise?
You guys may want to have that conversation, but melatonin is, I think, a tonic for the world. So melatonin is, as a compound, it's tremendously neuroprotective and antioxidative stress. So it's an antioxidant and it's neuroprotective, also anti-inflammatory. So it's good for your brain. And for people who can tolerate it, it is a really beneficial sleep aid. What's interesting about the way melatonin works as a nutraceutical is that it doesn't create the kind of rebound insomnia that you get from taking Ambien or whatever, trazodone or whatever else you might be prescribed by your physician. P.S. Do not have the conversation with your physician about sleep disturbance, because you will almost always just get a sleep med, which is never going to be helpful in the long term. So cognitive behavioral therapy for insomnia is the gold standard for treatment. Melatonin, because it's available in this country over the counter, can be a really useful tool for people who can tolerate it, who have a benefit from it. Some people will use melatonin and be like, I got nothing. I don't feel sleepy. I feel like I'm wide awake and I had 10 cups of coffee. And some people, it's more effective. Start little, 2.5 milligrams, and play with it. You guys are, as caregivers, you are more expert researchers than the doctoral level researchers that I work with every day. So you know this world, track it, see how you respond to it, play with the dosing. For people it works for, it's pretty magical intervention.
I take the time release, and it is great.
That's great.
You mentioned that. Yeah, it really is
Totally
good.
great. Yep.
We also had a chat that came through that I think is also important. Somebody who doesn't really have resources, family or friends that can come in, and has other complications with a daughter who needs a handicapped daughter, and somebody who's got the PF and a caregiver, and just feeling so overwhelmed. But when there really aren't resources within your your family and close friends, or even with this particular support group, are there social services that can help in these situations?
I was just reading Kathy's post, and it's so horrifying to feel so stuck and to not have the support of a medical provider, and to feel completely abandoned by the system that would purportedly be there to help. I wonder, Kathy, if there's some way that this network could be helpful to identify someone who even could consult on your case virtually. So now, thanks to telemedicine, it's a lot easier to have a provider who is remote to you. So you might be able to get some better care or a second opinion from one of the pulmonologists that someone here on the screen feels really connected to. Or so,
Dr. Grogens, if I may, which is not announced yet, and I'm not announcing it, but just to tell you, we are doing something with NAMI, the National Association of it's kind of a grassroots effort, if you will, focused on depression and anxiety, and we're getting ready to announce that probably over the next 2 months with some programs, documentation, books, guides, and webinars.
Love it. I get to do a lot of work with NAMI, and they're an extraordinary group of people too, and have tremendous family member support, especially. So, Bill, that's a great transition for Kathy to talk about all of the resources available for mental health support. So most of those are available also to you free. on the end of like, how do you get respite care in a home where you have two people who would require care? And Kathy, you may need to work with your local United Way and find out who are the volunteer healthcare organizations. You could send a visiting nurse over. Is there some kind of group local to you who could offer respite? It may be that you are getting crafty in doing something where you could have telesupport so that you could even step out of the room. So it's going to be imperfect. It'll be whatever you build. This is about keeping you afloat. Kathy, your daughter and your husband need you to stay afloat more than ever. And they're lucky that you're fighting so hard to stay afloat.
Is that all there is?
Any other questions or comments? Because I can just keep going all day, and we have about, we only have about 10 minutes to go. So we'd love to hear from you. If not,
Shelley,
go ahead. Yes.
I was just going to ask about the melatonin or any sleep aid. I never like taking any of that because I know that some of it can knock me out. And it may not be the same now, but back when he first came home, I always wanted to make sure I could wake up, in the middle of the night if he needed me or anything like that. So does melatonin, I've actually never used melatonin. Does melatonin do that to people? Knock them out where you really can't wake them up until they wake up?
That's a great question. And I should have mentioned that. And it's one of the unique challenges for caregivers with lung disease is that one of the reasons that your sleep is disturbed is not only all of the stress, which is sleep is the bellwether for all of the stress in your life, but also because part of your brain isn't resting because you're listening to your partner's breathing, or that you're ensuring that they've got their mask on if they roll over, or right. It's like all the ways that your sleep stays light and you don't get the benefit of any of that slower wave sleep. So that takes a real toll, right? It has a very clear lifespan related toll, right? There's the stakes could not be higher. Interestingly, and Roseanne, you might want to play with this a little bit. Melatonin is produced by our pineal gland in our brain, and our brain produces melatonin. The pineal gland produces melatonin in darkness. One of the ways we get in our own way about falling asleep at night, if like me, you are guilty of having a screen, watching TV in bed, what the blue light is doing, there are blue light receptor cells in our retina that suppress melatonin production and increase the production of norepinephrine or noradrenaline, which is a hormone that produces vigilance. So it's the exact opposite of sleep. So when they talk about don't have a screen in bed at night, that's because you're laying in bed, I'll just watch a show until I feel sleepy. And literally all the while you're sending these actual signals to suppress the production of the hormone that would make you feel sleepy, right? We feel sleepy as levels of melatonin increase. It's also why people who live in areas with less sun over the winter time can have a really hard time, especially for caregivers. That can be like a way to bottom out is when it's dark, the days are shorter because we produce more melatonin. What supplementing melatonin does is gives your pineal gland a little bit of a jump start. So if you're not supplementing with something you're not producing anyway, what you might be doing is cheating the system a bit. If you are using a screen, take a melatonin, and it's going to ensure that when you're done watching your show, you're going to feel sleepy, which you would have done if you'd stayed in bed doing sleep hygiene for the hour. Frankly, that's better. But it's also, interestingly, when I mentioned that doesn't have the rebound effect, with sleep drugs, what happens is, this is true for all drugs, right? You have to take more of the drug to get the same effect. You build a tolerance to it. Something about the way the pineal gland produces a variable amount of melatonin on its own makes it almost inured in some way to rebound effect. So it doesn't develop a tolerance. It's your pineal gland will still produce the same amount of melatonin if you weren't taking melatonin as a supplement.
And Roseanne, I take 1 milligram time release. My doctor couldn't believe I would only take 1 milligram, but I'm very sensitive also to anything. And it works really well.
I love that. I didn't even realize it came in 1 milligram tablet. So yeah, start there. That's a great way to start, and log it, right? And you might engage your husband in the research and say, hey, if you happen to wake up during the night, would you nudge me and see if I wake up, and let's just try this out.
Okay, thank you.
Yeah.
So any other questions or even final comments from Dr. Gorgens? Go ahead.
One of the other issues that with dealing with caregivers that we're facing, and I guess it's going to be here still for a while, is on many appointments, my caregiver can't go with me. And that breaks a communication chain that's difficult to fix.
I didn't know you wanted me.
That was because of the pandemic, Jim, I guess.
Yeah.
It is very frustrating. And that actually caused us to not use, one of the reasons why we didn't use that facility anymore, but it wasn't the only reason. But it is frustrating. It is frustrating because I need to be there. I do need to be there.
Yeah. And James, you may appreciate when Marianne is there to
not always
ask questions you may not have thought of. In circumstances like that, how far out of the box can you think? Can you get your iPhone and have Marianne FaceTimed in? Can they use their telehealth platform to get her into the room virtually?
I've tried that, and many they just don't want to be bothered. That's something that's just not something they want to talk about. So
yeah, and Jamie, if Marianne were in the room, she'd insist on it. And this is where she's going to want you to channel your inner Marianne and say, you know what, I'm an N of 2. You're treating 2 people here. Only one of us is in the room. And I really need to ensure that Marianne is part of this conversation. Let me get her on speakerphone here, or whatever is going to work for you.
One of the interesting things is our transplant team in Houston requires the caregiver to come in the room, and they never excluded the caregiver, which was great. It's the other doctors that we have to deal with, all the other disciplines.
And the change in the landscape, we didn't really talk about this, but there's more and more research about the benefit to outcomes of involving a caregiver. So as physicians are better incorporating current research into their work, and as the systems are trying to leverage all the ways to improve patient outcomes, you'll see a greater and greater reliance, like your transplant team, on caregivers.
Mm-hmm.
I might add that some doctors, because we have a situation with somebody in our family who was they were actually caretakers of this person, and they all 3 of them, the couple and then the patient, were in the doctor's office, and this patient needed to be in a nursing home, but the doctor did not want the 2 people who were caring for him, who actually were taking care of him at their home. He did not want them to speak. He wanted the patient to speak. And so the patient just floored the doctor and didn't really, I think the doctor couldn't perceive what was going on. The problem was when the caretaker opened up his mouth, he said, I want to hear it from the patient. So there's the old school that doesn't want anybody to talk but the patient. Many times the patients are not giving the correct information.
And the provider is going to be making that juggling act in real time. So they do want to prioritize patient complaints, and they also need to provide space for caregivers to ask questions, to ensure that everybody leaves with the same set of plans between the next visit. I mean, it's got to be both.
Right.
It's an important reminder. Yeah.
Dr. Grogens, I'm sorry. We've hit our timeline, and I think this has been, without a doubt, one of the most interactive, best meetings that we've done forever. It's just been, your comments are so dead center to the realization of what we're living through as a group, as patients and caregivers. And I want to thank you for volunteering your time on a Saturday morning. I know there's probably many other things you could be doing, and your time is really valuable. But this has been, I think, I'm sure everyone here agrees with me. And Shelley, I have to comment, you just get better and better and better at this. You really are. You missed your calling in life. It is, I think you should be an MC or something, I'm not sure. But maybe she deserves a battlefield commission to a PhD, Dr. Grogens.
Yeah, I agree. Shelley, you've got that in the bag.
But thank you so much for being here, and all of our warriors, thank you. You're going to love some things coming up. This is one of the topics we're spending a lot of effort on. I've always felt, and many of you that know me know I've said this to you, I think the caregiver in this whole team that we have of patients and caregivers has the heavy lifting and the tough job. It's easy being a patient, you are, but a caregiver has to make a conscious decision, and it's very, very hard duty. And many of the people that have talked to her this morning I've talked to as well, and I understand what it is. But Dr. Grogens, sensational presentation, and thank you for being you. You speak with your heart, not just your mind, and I think we all respect that.
I so appreciate that.
Right.
Thank you, Bill, and Shelley, and to everybody. I'm thinking of you, thinking of everybody who's on the list, who's recently been off the list, sending everybody my best. Holler if I can help.
Thank you so much. Bye-bye, everybody.
Bye.
Bye-bye.